and we identified several, in fact many, significant deficiencies in our care process. A couple of the lowlights of this review: it was taking us nearly 5 months between first contact with the health service to start treatment of colorectal cancer for our average colorectal cancer patient. It was taking over 3 months, 100 days, for a patient who was referred from general practice with a bowel cancer screening program positive stool test to get their colonoscopy. And within these dreadful access times, there were even wider variations because there was no consistency of triage for being seen in the clinic, there was no consistency of triage category for actually having a procedure done, and there was no relationship at all between the triage category decided for either clinic or for a procedure and what was actually being delivered when the patient was turning up for either clinic or procedure. So we started a project which has run through the last 5 years and is continuing today. So our main aim at the beginning was to improve the time to scope for a positive patient, a stool test positive patient, and for this work we got a Cancer Institute project grant in 2013. And it started with an enormous amount of preparatory work that took best part of a year by Donna to organise a new way of delivering our colonoscopy service for these patients. That preparation was critical. It was critical because you have to take with you all of the people in the system, from the people who receive the referrals in the referral management office in the hospital, to the secretaries working for the clinicians, to the people who are organising and booking the scopes in the administration part of the theatre complexes, and to the theatre staff themselves, the anaesthetists, and everybody else involved in the process. We were doing this across 3 hospitals in Newcastle because our endoscopy service is delivered on 3 different sites in Newcastle. So you have to prepare people, you have to explain the reason for changes, you have to go through the practicalities of the changes and the new methods of working, and you have to solve the problems that come up. And those are always problems that you never anticipated or never expected would be a problem. We were aiming to streamline the booking for colonoscopy. We were not aiming to provide an open access service where a GP could just request a colonoscopy and it would be done. We still needed to maintain a gatekeeper triaging process to make sure that the colonoscopies we were doing were appropriate and were safe. We wanted to rationalise this to consistent standards and maintain those consistent standards. And the bedrock of that new service was a telephone triage and booking service, replacing the initial outpatient appointment between a specialist and the patient. The old pathway, it was taking an average of 2 months, 60 days, for a referral from the GP to be seen by a specialist either in their rooms or in the hospital clinics. It was then taking nearly 40 days, another 5 to 6 weeks, between being seen in the clinic or rooms to getting their scopes, to make the average of 100 days. Under our new pathway, after the first year or so, we'd settled down to having an average of about 6 days from referral to being dealt with on the phone, and then for about 7 weeks to get them seen, between 6 and 7 weeks, to get them seen and actually have the scope done, making a running average in recent times of about 55 days for the pathway, a significant improvement on the 100 days before. Part of our issue in managing this and not achieving our target, which we would optimistically hope to achieve the guideline target of 30 days from referral to scope, is due to increased demand on the service. And part of that demand has come from increasing external pressure and increasing need for these scopes to be done. Over the time that we've been doing this project, the bowel cancer screening program has extended from only offering screen tests to people aged 50, 55 and 65 in 2013 to, by the end of next year, everybody from every 2 years from age 50 to 74. The bulk of the increase in those screening frequencies occurred in 2015 and 2016. We've also seen a steady increase in participation rates in the bowel cancer screening program itself, and there's a significant number of FOBT tests that are done that are instigated in the community by GPs or by other organisations. So we've seen an increase in participation, and we've seen an increase in the total number of scopes tests being done, and so we're steadily seeing an increase in the number of positive tests. And we saw, for example, an increase in over 10% between 2015 and 2016. This is a graph which shows the red and blue lines of 2015 and 2016 numbers of scopes, the number of scopes by age group. So you can see in the middle of the graph here, the age group covered by the bowel cancer screening programme between 50 and 74, and you can see the bulk of the increase was in the upper age groups in that area. In fact, pretty well all of the increase in our scopes in 2015 to 2016 appears to have come from increased testing through the bowel cancer screening programme. We've also extended the indications for using this service. One of the project grants we got from Cancer Institute New South Wales was to extend from the screening programme to symptomatic patients. That grant ran from the middle of last year to the middle of this year. From September last year, medically fit patients over the age of 45 who'd been referred to clinic with rectal bleeding as their main symptom were booked direct to scope. They didn't have to come to be seen in the clinic. And this has increased, if you like, our internal demand from service development in Newcastle. This graph shows the increase in the referrals per month. From way back at the beginning of the project in its pilot phase in between December 2013 and the middle of 2014, when we were dealing with 15 to 20 patients a month, to over the last year where we've been dealing with, on most months, more than 100 patients a month through the booking service. How have we done? Well, the most important metric is the time from referral to scope. It was 100 days before the direct access service was introduced. This is a slightly odd graph in some respects. It's an average of the last 30 patients and the time that they've taken moving through the last year or so of our service. So by the middle of this year, the last 30 patients were taking on average 42 days to get through the system. We're slowly, very slowly but steadily bringing down our access time from around 100 days at the start of this project to now, with much increased demand on the service, to about 40 to 42 days. So I said at the beginning that I was going to tell you where we started, what I think has worked. Now I'm going to tell you what I think has not worked and some of the reasons why we think they haven't worked. What's definitely not worked is the process for our medically less fit patients. And we've also struggled to keep up with the capacity in providing enough endoscopy opportunities, enough endoscopy slots, if you like, to meet this demand for the service. This is the graph, last 30 people, average days to scope, for the patients who we were able to successfully book on the phone through the direct access service. That average is around 65 to 70% of all of the people referred to the service. About a third, between a quarter and a third, and a slightly increasing proportion in the last few years as our age group has got slightly older, are not medically fit enough for us to be able to book with the strict triage criteria that we put for our nurse-led service. You can see for the people who are fit, we've averaged around 40 days for most of the last year. This is the same graph, but for the people who were not fit to be booked on the phone. So people had to be diverted to go through clinic. And you can see at the beginning of last year, or middle of last year, we were averaging about 150 days to get these people seen and get them to scope. And for the middle part of the last year, we were averaging around 120 days. We've got the average down to about 100 days now. That's still better, but it's still pretty awful. It's not good enough that these people who are, in many ways, our more vulnerable patients are waiting longer. We looked hard in the middle part of this year about why, and we found that part of the reasons is slow access to the clinics that these people had to be sent to. If they were sent to one of the colorectal surgeons, myself or my 4 colleagues, we were seeing them in about 50 days. Likewise, my general surgical colleagues were seeing them in about 50 days. The gastroenterologists were seeing them in about 80 days. And then there was a fairly constant period to get them to a scope unless they needed other medical intervention first. We've responded to that by better control and monitoring. Put simply, if we asked for a clinic appointment, we used to assume that it was going to happen. We've now realised that you can't assume anything, even in a fairly tightly controlled system, and you have to chase them down and make sure that Mrs. Brown really does have an appointment for next Tuesday week, rather than, yes, it will be done. And the delivery of the clinic service by the clinicians is, to say the least, a bit variable. It's still the case that there are an awful lot of low-value follow-up appointments being seen, using up clinic time, which could be better used for higher-value healthcare. The other issue that we faced is capacity. We have 30 plus endoscopists in 3 public hospitals in Newcastle providing the service. In the first few years of our service, we added 1 or 2 patients per list as we interned between the endoscopists to try and get these scopes done. A couple of our endoscopists refused to take part, but most agreed to go along with that. As our numbers rose towards 100 patients per month, this caused issues with perception. These scopes were displacing routine scopes. Those that were booked for 90 or 365-day priority. Now, some of those patients are in surveillance because they've had high-risk polyps or they've had a cancer in the past. They're actually very important patients because they are the people who get the highest yield of actual pathology when you scope them. And so they're at risk, and if we're displacing those, we're actually not doing the community as a whole a particularly good service. We responded to that in the middle of this year by creating 3 dedicated lists just for direct access scopes. We now have 3 of these each 4 weeks, where we can do 8, 9 or 10 scopes depending on the anaesthetist, and that's helped us meet our capacity, but it's really only helped us keep up with demand rather than create an improvement in our access. So what are we doing now? Because we can't leave things alone, we're looking at waitlist management. We're looking seriously for the first time at what we're doing and why we're doing it. We did a pilot project last summer where we reviewed the waiting list of 2 of our endoscopists. At least 10% of the scopes that were on those waiting lists were completely unnecessary by any recognisable guidelines or clinical indications. But 5% of scopes were seriously overdue, so we were doing badly in both directions. Other evidence that we've done through student projects and other audits and such like suggested that between 25 and 40% of the scopes that we do might be completely unnecessary. So our intent is to develop a better waitlist management process which creates capacity for the timely scopes from whichever cause, whether it's the bowel cancer screening programme, symptomatic or surveillance, that mean we can get those things done as we need them. Even if we manage to create 10% of extra capacity by moving things out that don't need to be done to moving things in which do need to be done, in our service that's over 500 colonoscopies a year. Thank you for listening.